Hey everybody, thanks for coming and thanks for being here and giving me your attention. Today we're going to be learning about a little bit different field of medicine from physical therapy. It's going to be about licensed practical nurses, the nurse practitioner, and the registered nurse. This project has been a conjoint effort from Paul Elkin, Sarah Joyner, Kevin Soto, and myself, Jake Williams. So, what is a nurse? What do they do? Well, there's three different types that we're going to be talking about. The licensed practical nurse, LPN. They're kind of like the lower end, basic, the entry level, if you will. They administer wound care. They're inserting catheters, checking vitals, really basic level stuff. They're the basic, like I said, the basic person. They're a lot of times in a basic setting. They're not in a high intensity setting. They're not going to see them in the ERs. They're a lot of times in outpatient doctor's offices and that sort of deal, just doing kind of minimal tasks. Not to say their job's not important, and that they don't do a great job, but just a perspective comparatively. A registered nurse, they're a little bit higher. They're a nurse that they evaluate and coordinate patients under the care of the physician, so they kind of are the liaison. They're a really good liaison between the physician and the patient. The physician, a lot of times, historically, physicians don't have really great bedside manner, and that's when the RN comes in and just steals the spotlight, So they provide education to patients in various health conditions. They do help with diagnostics and analysis with tests, and they do administer some treatment and some medications. Again, it's limited and restricted state by state, but that is a possibility. And you do see registered nurses in more fields and settings than you do in LPN. And finally, the nurse practitioner is a nurse even higher. They can serve as a primary care provider, and Sarah will be talking about that, and talking about Georgia specifically. But they're able to do basically what a physician would do, except you don't have to pay this high copay, which is kind of a neat idea. They provide advanced nursing services to patients. They can prescribe medicines, they can treatment with the physician approval, but the physician doesn't have to be there. And then they create a plan of care and alter plan of care as needed. So now I'm going to let Paul Elkin take over.
So I'm going to be talking about more of the education of an LPN, an RN, and an NP. The LPNs, it's just a post-secondary degree after high school, about a 1-year type of thing, 60-hour credits. You have to pass the exam, but not a whole lot here. I feel like it'd be a whole lot on the job training once you got in there, what they wanted to do, and I'm sure there's all different levels of skill where these LPNs, once they come out, what they end up doing, what they end up working, and as you progress, you can work more and do more. And then next, I'm talking about the RNs. And RNs is a associate's degree. Some schools you see they have a degree that you can get without getting a full bachelor's degree, full 4 years of college. You can start nursing school in the middle of that and get this associate's degree. Also, they do have a master's of nursing that you can also get after your full 4 years of undergrad. And they also must take a licensure exam and keep this up. So, and then the last level is the nurse practitioner, and they must first get a registered nursing degree and then work for a couple of years and then go back, go to nurse practitioner school, and this could be either a master's of nurse practitioning or a doctorate level program. And this allows them, as we've said, to basically be a practitioner, see their inpatients, and do everything. I'm going to turn it over to Kevin.
So this, guys and gals, is where we talk about their interaction with the physical therapist, right? What we're mostly concerned about. So the big thing in the healthcare team is this thing called a case conference. That's where everyone within the healthcare team taking care of that patient, they come together, they talk about the patient's diagnosis, their plan of care, what's the best intervention they can do to help them. These conferences can happen physically in person, or they can be electronic or online. And sometimes even the physician will show up. He'll be part of that crew that comes in together, kind of coordinate everything what they're going to do. PAs, OTs, PTs, RNs, everyone's in there together. They report findings and changes in conditions together or to each other. That way they can better coordinate and collaborate and help patient satisfaction, treat them, make sure that what the initial problem is taken care of and that the patient is satisfied overall with their care. And I'm going to turn it over to Sarah to talk about direct access here in Georgia.
Okay, so I'm going to talk about two issues that are kind of important in the nursing field right now, short staffing and direct access. So especially in Georgia, there's kind of this push to stop hiring as many LPNs, which leaves a lot more work spread out on fewer RNs. So that can lead to a lot of short staffing, overworking, and that can just cause a lot of problems within that field. Another issue that's a problem is direct access. Georgia is one of the strictest states when it comes to direct access policy. For instance, in many states, a nurse practitioner can be the primary care for many people just coming in to see them, but that unfortunately is not allowed in Georgia. It's something that they're kind of pushing towards, and we might see later in Georgia. And with that, we're going to move on to some interviews with the nurses just to kind of get their viewpoint on all this.
Yes, my name is Kelly Skelly. I'm a registered nurse at Augusta University Medical Center, and I work on a cardiac step-down unit, and I've been there for about 2.5 years.
Okay, we just have a few questions for you. So our first one is, how would you describe the expectations and role of physical therapy in healthcare?
So my understanding of physical therapy in the healthcare system is that of rehabilitation. So you see patients who have either had a life-altering or life-changing injury or procedure or surgery, and help them basically rehabilitate them back to their baseline, back to normal, or help them find out what their new normal will be. And then also I've known people who where medication for pain management has not been effective for them or is not appropriate for whatever reason, and physical therapy has played a huge part in their lives as far as just increasing the overall just quality of life for people, and just helping them return to their baseline or help them find their appropriate level of functionality.
Okay. And how would you describe your interactions with physical therapists in practice? In what ways do you think PT or RN or NP relationship can be improved?
So my interactions are in an acute care setting in a hospital, and they have been very positive. We work very closely with the physical therapists in our unit. In our unit, we have patients who have the two things mostly that the physical therapists do in the floor in which I work is they help mobilize patients. So patients who have had any major cardiothoracic surgery or procedure, they help get them back up and moving after that procedure. And then patients who have had prolonged hospital stays and who are very deconditioned, they help get them back up and moving as well.
Okay. And what would you say is the biggest social barrier that you face in practice?
So there's many. With the patient population that we work with, we work with a very low income. The majority of our patients are lower income, and so there's many social barriers that inhibit them from having taking care of themselves and having a good quality of life. And the two that I see a lot in my setting are access to nutritional food, because food in itself can be a medication for these people, especially for patients who we see for congestive heart failure. A low salt and low sodium, low fat, and low cholesterol diet is huge for them in managing their care, and just having a basic understanding and education of that is important. But also just I think the limitation for them a lot of time is why we see them readmitted is just limited access to that, especially in the communities they live in. They're responsible for taking care of not just themselves but other people, and so they're going to cook foods and eat foods that are pleasing and tasting to the other people and not just themselves. So they feel that responsibility to take care of others sometimes before themselves, and a lot of times we see hospital readmissions for that, just a lack of care, lack of taking care of themselves as far as what they eat, just their basic low salt, low fat diet. And then also medications, just not having the appropriate funds and finances to make it a priority to make sure that they take their medications and that they get them. On our unit, we have a collections place where we put loose change or anything in to help patients who at discharge say that they just don't have money to pay for their medications, and so we help pay for them so that we know at least they're getting a month of their medications when they're discharged from the hospital. But a lot of times we see readmissions as well for the same reason, just not following up and not being able to fill them, and then obviously not managing their chronic illness, whatever that may be, and then seeing them readmitted for that as well. So medications, limitations there, and then just diet.
Okay. And is there one particular law or rule that you feel limits your ability to be the best practitioner that you can be?
I have thought about this question a lot, and there's really not any law or anything that I feel like inhibits me. Like I said, working in a hospital, I have like a very clear scope of practice and interactions with other disciplines and physical therapists, respiratory therapists, doctors, and so I don't feel limited. I feel, especially working in a teaching hospital, very free and as far as like my scope of practice and what I'm able to do. And I feel like the laws that are in place for us are for our good and for the good of the patients, as far as like HIPAA and negligence and all those things. Like they're for our good and for the good of the patient. So there's nothing that limits me as working as an RN in an acute care facility that I feel like I can't do, or that inhibits me from doing my job to the best of my ability.
Okay. And what are your thoughts on direct access for NPs in Georgia?
I'm not an NP, and so I don't really have any thoughts on that question.
Okay. And can you give an example of your most fulfilling moment or experience as an RN?
Yeah, so I couldn't think of like a particular moment, but overall I really enjoy my job. I love what I do most days, and it can be challenging. Let me do it this side first, in that, like I said, seeing patients who have readmissions and who don't necessarily care as much about their health care as I do, and giving patients education and the materials and resources they need as far as medications and all the tools they need to take care of themselves, and still seeing them back. We call them frequent flyers. So every couple months I discharge somebody, I'm going over all their stuff. I'm like, okay, I'll see you in a few months. Like they just don't care and don't, whatever. So that can be frustrating, and that can make me feel like I said, I just show up and put Band-Aids on people and go home and just do the same thing over and over when the cause is really a lot deeper. So that's frustrating. The good thing, the most fulfilling thing about my job, for an example, is seeing patients all the way through. So if we'll have a patient who's admitted for chest pain, and they'll go for a heart catheterization, and then they'll come back to our floor, we'll rehab them, and they'll be diagnosed with like multivessel coronary disease, and then become a candidate for cardiothoracic surgery, for open heart surgery, to have bypass. And so we'll prep them for surgery on our floor, and then they'll go for surgery. They'll go to an ICU, depending on how things go, anywhere from like 2 days to a week, and then they'll come back out to us on our floor, and we will rehabilitate them, get them off of oxygen, get them up and moving and eating and taking all their new medications, educating them on all the new medicines that they weren't on before, taking all their drains, tubes out, and then we actually get to send them home with all the resources they need. So it's like when we see patients through all the way from beginning to like the end, and actually being able to like play a part in that and help in this like big thing that's happened in their life, to be with people in like the hardest time in their life. People who are sick are generally not like happy or pleasant, and to be there to advocate for them and to help them is a very like rewarding experience in general. But I enjoy, like I said, seeing people through, seeing people who care, and then to see them later on the street and see how well they're doing because of the care that they've received from us. So
Okay.
that is rewarding.
Well, thank you very much.
Thank you.
I'm Lindsay Moore Murphy, and I'm an acute care nurse practitioner that practices in the emergency department at MCG.
Hey, thanks, Lindsay. We're going to ask you a few questions here, and just give us your thoughts. So the first is, how would you describe your expectations for physical therapists in healthcare?
Sure, I think physical therapists are very versatile. I have worked in a variety of settings, inpatient and more outpatient. I think physical therapists can definitely help patients really go through rehabilitation. And so they play multiple roles, especially on the back end of actually rehabilitating patients back to being active and being healthy, but also helping us assess where these patients are and where they need to be and how they need to rehabilitate. And I depend a lot on physical therapists in my roles in the past on telling me how to actually get a patient back to an active and healthy lifestyle.
Okay. And how have your interactions with PTs been in practice, and is there any way you think that could be improved, like the relationship between NPs and PTs?
So I have a little bit of experience again in inpatient, and the relationship there was definitely me leaning and relying on the PT to tell me if a patient was really ready to go home, or what type of setting they really needed to go to enable them to be safe at home, whether they need to go home or inpatient rehab or to nursing home. And I think that's really important, that we really listen to each other. I work now in the emergency department, and unfortunately I don't have a lot of interaction with PTs, and I think that's something that we definitely could use. I see a lot of people with chronic back pain, a lot of chronic injuries, And I think if we had physical therapists to really help and work in the ED, we could definitely cut down on a lot of the bounce backs and a lot of chronic visits. And not even so much the chronic stuff, but even acute stuff, because you're able to splint and everything else, and I think that would definitely help our overcrowded emergency departments.
Okay. Is there any social barrier that you would point out with your practice that you face regularly?
Yes, I would definitely, absolutely. I think in every part of healthcare, we could definitely point out education as being a barrier where people don't understand what led to their point where they are now in their health, and then where they actually need to go. Because of that, I think sometimes patients come to me in the emergency room wanting a quick fix, of just one pill that's going to fix their back pain, one pill that's going to fix whatever they've done for years to themselves, and they don't understand that it takes years to do it, and it's going to take years to get better. And I think that's a huge social barrier when you're talking to someone and how they actually have to do a lot of work in their own healing process, and there's a lot of problems when they're unhappy with it and they continue to just bounce around to different physicians and different providers or different disciplines, just looking for the quick fix.
Okay. I want to move over to talking about direct access for nurse practitioners. I know you've told me that Georgia is one of the most restricted states. Can you just kind of tell me your thoughts on that?
Sure. So our scope of practice is dictated actually by state. So a lot of physicians and PAs are dictated more on a national level, and we go by state. And yes, Georgia is one of the most restrictive on nurse practitioners, really as a result of some of the rulings from the Georgia Medical Board. So direct access would obviously help with reducing the unfortunately very large ratio of our provider to patients. There's just so many people in Georgia that don't have access even to primary care. And if we could establish something like direct access where someone could actually just see a nurse practitioner, there would be a large amount of cut down on the overburdened health system, and a reduction in ER visits and a reduction of urgent care visits, and people would be able to see their primary care a lot sooner and a lot more efficiently. We are able to practice independently in many states, and that's something I think that definitely needs to change in Georgia.
Okay. And lastly, can you just give us like an example of a moment or just like something you're very passionate about as a nurse practitioner that just was very fulfilling to you?
Over the last year, I've been doing an international medicine fellowship out of the emergency room, and in that last year, I've had a lot of opportunities for education, and that's education both here in the United States and education overseas. And it's always incredibly rewarding to be able to share knowledge with someone so that they are able to also independently practice and affect the people around them. An example, we were actually working in a malaria endemic area in Africa, and we worked with some of the techs and some of the nurses there on just doing basic malaria smears and doing malaria diagnostics so that they could turn around and continue to do that and treat their own patients there. It's all about empowering other people to serve and to take care of people around them.
Okay. Well, I appreciate your time.